It is 5 o'clock, so let's call the Kittitas County Public Hospital District #1 meeting for January 2nd, 2025. Order. Do we have, you had a chance to look at the agenda? Entertain a motion to approve the agenda. There's changes.
I'll improve.
I'll second. Second.
Move to approve.
Moved by Erica, second by Bob. Any further discussion? All in favor, say aye.
Aye.
Aye. That motion is approved. We've had a chance to look at the consent agenda. I'll entertain a motion.
I'll move to approve the consent agenda.
By Terry,
Second.
second by Bob. Any further discussion? All in favor, say aye.
Aye.
Aye. Any opposed? That motion passes. Now we're to public comment and announcements. If there's anyone who would like to make a public comment or announcement, this is the time. If there's anybody online or in person. Hearing none, we will move on to section 5, reports and dashboards. So we have quality, Mandy Olson, Chief Quality Officer.
See her.
There she's online. Hi, Mandy, go ahead.
Hello. Hey, first, I just apologize if my audio is bad. Please do let me know.
So
if
far,
it cuts
so
out.
good.
Okay, it's a little bit sketchy here as far as the service, but my report starts on page 17. So first, if there's any questions about the dashboard or my report, I'd love to answer those.
Does anybody have any questions?
At the quality improvement meeting, we looked at these dashboards and they were 100% great by the quality committee. But if you do have a question, like John said, you should ask about it. But these dashboards, she talked about them at our last quality meeting and she did a really good job. I just wanted you to know about the discussion that we do at the quality meeting about all this information.
Good, thank you. Anybody else have any comments?
Mandy, are there any updates to respiratory illness? I know things can change dramatically between report and meeting.
Well, I've been a little off the grid, so they made those that were at SLT this week. I know we discussed, there was supposed to discuss a little bit about it at SLT. I don't have an update.
Okay, no, that's fair.
Yes, the public health department did put out there's a rise in positive cases of flu, respiratory viral infection. So just the recommendation to use standard precautions, ensure we're masking, masking patient facing areas. So recommendation. So yes, the numbers are increasing our side of the mountain and the west side of the mountain. So we did have 2 positive pertussis cases in the county, only 2 that I know of. One of them was at the Discovery Lab as their letter reported, and then one with the wrestling team. So yeah, my son was one in the Discovery Lab that got tested, and they're all in the clear. So
Not a
yeah.
fun test.
yeah, he did good.
When you said the word flu, I think we should mention the fact there's some bird flu going on around the United States, but I don't think we've had a problem with bird flu in this state at all. But there's been a few people that have died from the bird flu. And that's why I thought we should mention the 2 types of flu now, not just the regular human flu, but the bird flu. Is that right, Dr. Martin?
Well, the concern, we're talking about different flavors of influenza A. And we're concerned that if avian flu starts spreading in mammal to mammal, it's harder to contain because it's flying around. But in terms of prognosis or treatment, they're the same. I believe the current avian flu is an H5N1, and I believe that there is an H5N1 in the current vaccines. Mandy, check me on that because I don't know that.
I don't remember, but I do know that last I heard, there were concerns for avian flu in Washington State and some animals, and they were concerned for exposure, but I don't believe we had any positive transference in our state yet to
I
humans.
understand as well.
Actually, I think historically that H5N1 that you're talking about flu, that was the one that killed all those little children back in the early 1900s.
The Spanish pandemic,
Yeah,
um,
that was an H5.
I don't think it was. I think it was either H1N1 or H3N2.
No, I think historically when I looked at it, when I was educated about it, it was the high number because it doesn't happen very often.
Interesting.
But I'm sure
Erica,
that if something pops up, we'll be alerted in a timely manner.
I don't think so, yeah.
Definitely mandatory reporting by healthcare providers, hospitals and labs, as well as we have a great relationship and weekly communications with our local health jurisdiction. And then Michelle's on calls. Is that weekly, Michelle?
Yeah, we have weekly calls at the state level. And to Erica's question, I have been in a lot of communication today with Nicole and Cody, just making sure that staff know they're comfortable telling patients that are appearing with respiratory syndromes to have the mask on. We've got the signage up. So it's just, it's another winter that we're going through: RSV, influenza, COVID. And our standard precautions, if we remind people and we use them, they seem to work pretty well.
Feels like we just did this entering a winter with respiratory illness.
It's kind of like your utility bills, getting up in the winter. Yep, but we all definitely still have PTSD from.
I was just talking to someone recently though that was asking me, "Oh, are you masking at your hospital?" And oh, it's because I remember even before COVID, during flu season, we'd have to mask sometimes. So it's not, this isn't, new just because of COVID. It is the respiratory illness season is upon us. So.
Any other questions for Mandy on that part? Mandy, I was gonna ask, I don't know if you know, but on the QI Council, there's a note that says Jeff Holdman reported the outcomes of root cause analysis related to a staff injury. I don't want to know specifics, so I just wasn't sure, what we learned from that. Is there something interesting, or if you know anything about that investigation?
I do. What I can say is this was a rare root cause analysis where they really felt like they had anticipated an issue. They had done everything they could. There was maybe one thing they thought of, which was, do we absolutely really need this test that we are considering doing for this patient? Is it going to change the outcome for them? Or but that was the one kind of thing we said, maybe we could have done something different. But they really felt like, man, from the provider to the staff, everyone was doing all they could to prevent this injury. So.
Okay, thank you.
Mm-hmm.
So, I know we're gonna move into the 2025 QAPI, and I think we have action on that tonight. Is that?
Yes,
You're gonna need a
please.
vote from us and stuff, so,
I am, yes.
all right. Do you want to discuss that at all? Anything about the QAPI you want to talk about?
Well, I just would remind you that Matt had sent an email out as the chair of QI Council, and Terry might have something to say, but they've been reviewed. All of these plans have been reviewed by senior leaders, their directors. The board has had the opportunity to comment, and we have received comments and feedback on them. And so at QI Council, we did recommend that the board approve these QAPI plans.
Terry, did you want to say something?
Well, you talked about Matt on his email, but he also talked to me privately because we're both on the quality board, or not quality board, quality committee, and we both discussed this about how the board will vote on it. And then he said we should also make an announcement at the meeting. Unfortunately, he couldn't be here. That this copy has been updated really good. And this will actually make this a happy new year with this really good copy right now.
Very good, thank you. So real quick, Mandy, on page 25, the complex service lines copy, core team members in the second paragraph. I'm just curious what we do with somebody like, Dee Dee has stepped away from the organization, but she's still listed on the copy before we sign off on it. Do we do anything about individual names and documents like this, or just not worry about it?
Well, the document will change as we use it too, well, as we go through the year. But I can also strike it and we can approve it with that removed.
Whatever would be, I'm getting a head shake, so I should just be quiet about it.
I think it's
Oh,
fine. I think it's more the content than the.
Yeah.
Okay, good. I just was curious.
And
Very
those,
good.
the team members do evolve as we
Yeah.
get started in it too, so we try to maximize everybody's time, so it might start with too many or not the right people, and those groups do evolve as it progresses. Okay, I know, like the Rev Cycle one, it's gonna be multiple different groups.
Yeah.
Different hands as it progresses through.
I kind of assumed that, but I just wanted to ask the question, so. So Mandy, what would you like from us next on this?
I would love a motion to approve the copy plans for 2025.
And all as a group, correct? All is submitted?
Yes, yes.
Okay.
Right, Jason, I don't think we need to separate anything out.
Nope.
Andy, okay.
All right, so the board members have had the copy in front of them several times and this version, and so anyone is ready.
I'll move to approve. I'm just always astounded by the amount of information, the attention to detail in each of these plans. It's evident that there's been a great deal of thought and insight. I'm so happily move to approve.
Motion by Erica,
Second.
second by Bob. Is there any further discussion? All those in favor of approving the 2025 copy plan as submitted, please say aye.
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 Aye. Is anyone opposed? That motion passes.
Yeah, and if Matt were here, he would have said aye also.
Yes, but he's not.
And thank you, the commissioners too, that attended that workshop at Hotel Windrow. It was a really good workshop, getting all the managers together to do this refresh and copy. It's exciting. There's a lot of work in them to come in 2025. It'll be good work.
I hear it was a very good session.
It was a really good session.
Excellent.
And thank you, Mandy, for making it a great session. She's a very good facilitator.
Cheers.
Thanks. I really have to say, I love this new copy process. I love how it helps us actually achieve a lot of our strategy that you help us develop. So anyway, I just think it's really working well and has a lot of our leaders very excited about the work.
So next up, we have the 2025 copy measures. And I believe
Yes.
this is something you also want to approve, Mandy, is that correct?
Yes, so these are what certain measures were required to report to the board every year, and they must be at least annually. So they would not necessarily show up on your monthly dashboard. But this also helps identify those that you do want on the monthly QI dashboard to the board. So there's a little color key at the bottom that kind of, the green ones are those that would be on your monthly dashboard, except for one, or there's a couple on there that are a little bit, I have that wrong. Because I see there's quite a few of there that are annual. But the greens are ones that have been reported previously. And a lot of them are monthly. The yellow are new. We still are working on the home-based primary care measure, and then the surgery first case start on-time percentage or delta change. That's new. And And the gray really come through QI Council as that annual or quarterly review. And then we do have a few to recommend to remove from the dashboard. And then there's a few that go kind of through senior leaders. They're not through, and they're not required. They're recommended by either the board or part of our, by leaders or senior leaders. It's part of strategy. So this was also recommended by QI Council to be approved by the board.
And can I just ask the title of the first column is QI measures December 2025. Is that correct? Have it 2025? December 2025?
It was drafted. No, that's not correct. It was drafted in December 2024 for QI measures for 2025.
You all wake up with where-
Title that
The
correctly.
header says December. It jumped us ahead a year and that confused me a little bit.
Oh.
It is confusing. That makes, I understand why you're saying
saw
that.
that.
It really should say, 2025 QI measures.
So
And it was-
basically the entire year, 2025.
Through December.
Yeah. And you can just cross out the whole bottom line and,
Okay.
it just should have a footer that said it was drafted in December of 2024.
Okay. Very good. Anything else you want to share with us about this?
This was also something new last year, in that these gray measures were ones that came to QI Council at least once and kind of in a different format than we've had before, and that seemed to work really well. So I feel like we've got a good balance of measures that need to be reported more frequently, like monthly through the QI dashboard, and those that it is fine to wait for kind of an annual review. And Matt would
Okay.
remind everyone, I know if he were here, that quality and the organization measure hundreds of things. This is not all the things that we measure, but these are the things that either must be reported to the board or we feel like need that board or governance level oversight. So just because it's not on this list doesn't mean it's not measured or monitored.
Thank you for sharing that. I appreciate it.
Mhm.
So we have the QI measures for 2025 in front of us. If there's no further discussion, entertain a motion to approve these.
Move to approve the 2025 copy measures.
Motion by Erica,
Okay, I'll second it.
second by Terry. Any further discussion? All in favor, say aye.
Aye.
Is there anyone opposed? That motion passes.
Thanks, Tom.
Thank you, Mandy. Is there anything else from your department?
No, I appreciate the approving the measures and the copies. Thank you very much.
Okay, thank you. All right, moving on. We are to the Chief Executive Officer report. In his first official meeting in that capacity, Jason Adler, welcome.
Thank you.
All right.
Yeah,
All yours.
I was debating if I wrote one report or two, so I started with one and I broke that to two. So at first, just introduction, Deb Callens and Dr. Thomas online as well. So Deb Callens started November 16th as our new chief nursing officer. That was well experienced and a few weeks in, really appreciating working with Deb and Dr. Thomas as well. He's been with us for a long time, so it's not as hot there, so. Then the chief financial officer position is the one that we're still working on. Been meeting with Janine. We're going through the applicants. We have screened phone screened, you probably screened 10 or so or more. We've got
50+ applicants.
We've got a lot of applicants, not a lot of well qualified applicants. But phone screen a lot. We're looking heavily at 2 right now and hopefully we'll bring a couple in the next couple of weeks to have some in-person interviews. So taking our time to get the right person. We've had a couple actually good applicants this week too. Janine just let me know. So we'll have to look through those as well. If you have any questions on my report, the write-up. Did I answer any questions?
Is the saline situation getting any better?
It's not getting better at this time, but I would say it's stabilized at its low point.
And it
So
sounds like
we
we've
have-
found solutions. I mean, we've been finding solutions.
We have found solution being the saline. We're not finding more, but we are getting a steadily lower supply than we want, but it's being matched with our conservation efforts. So just a huge shout out to all of our operations staff, our providers, and really limiting how we use those to limit how much waste we have really. So we haven't changed our practices necessarily or our services. We've changed our practices to use less, but more appropriately. So we don't just hang the 1 liter bags on everybody. It can be done with a 250 or something smaller. We're doing that. And our supply has been steady this last month.
So we've not had to cancel any procedures, or postpone anything because of this.
No, we were mindful of some total joint procedures, but not canceled or I would say postponed. So we were just mindful in scheduling those around deliveries.
The other thing that's probably worth pointing out is because of the nature of the equipment that we got for dialysis, we're not impacted there. We're not using prepared solutions. The machines essentially make their solution on the spot. So as long as we've got an adequate supply of water, and they keep sending us the cassettes, we're in great shape.
We just speaking potable water or special water?
The machine purifies it. It's tap water.
Well, I hope that doesn't ever become an issue.
Any other questions for?
Just a couple ads. So I would like to, I'll reach out to Wisha and I'd like to request for them to do a presentation to the board on running a levy. So I'll reach out to them and see when they could work that into the board schedule with the board president on an agenda for that once I get their timeline that they could do. It'd be Matt Ellsworth with Wisha to do that.
Jason, I think Matt is with AWPHD.
Sorry, PhD. Thank you, Michelle.
Uh-huh.
He did a really good presentation with Hospital District 2 about a year ago. So to do that with Hospital District 1, I think would be worth our time to get educated by them.
Did you say that there was a hopeful timeline on that or no? Did you-
Hopeful timeline to run a levy.
No, I'm sorry, for the presentation.
Oh, I'll reach out to them and see when their schedule lines up with our board. So
Okay.
hopefully within the next 2 board meetings.
Excellent.
And then Janine and I and others did meet with Teamsters today. And we do have a tentative agreement, handshake agreement. They're working on drafting it up and then it'll go through their vote and then to the board here.
If you don't get a good comment from them about the levy, I've been asked to be on the governance board for the Washington State Health Association. I can discuss it with a lot of them too, because that's when that meeting will be in February. If you don't get a good response, I can ask that to be on the agenda, and all the other commissioners that are on that thing, we can all discuss it, okay?
Yep, it's a service they do, so I think it should be very welcome.
Okay.
Yep, thank you. And yeah, so it was just really good negotiations with Teamsters. They're great to work with, great team, great employees. And look forward to getting that contract wrapped up.
So you've got a handshake, that's the next step, see it in writing sort of thing, is that?
Yeah,
Okay.
And then they'll take it back to their group for vote and then we'll ratify it.
What general would be a normal time frame for this process to play out at this point?
I already have the draft written. I kind of like the fact that if we control that, we can control the pace a little
Yeah.
bit. So I've already got the draft. We can review it tomorrow to just get a second set of eyes, make sure what I got is correct from our purview. We'll get that off to, then we've highlighted the changes to make it easier for their committee to take it out to staff to get a vote. Because if they have to hunt and peck and find and figure out, that's gonna take that much longer to get a vote. My hope is a month, but that might be a little ambitious. I don't know how fast Teamsters can turn it around on their end. But
Mm.
we can definitely get them a final draft, I think, by, from our perspective, like they could take it to their committee and put it out for a vote. We can get them the draft by tomorrow afternoon.
Very good. Yeah, hopefully by the next board meeting, we'll have it all. tied up.
Sounds good.
Yeah.
Good. Anything else on CEO stuff, Jason?
Nope.
Okay.
Talk about the leak at the.
Yeah, next.
Yeah.
Yeah, so winter's here, chasing water. So far, no broken pipes. Last year was broken lines, but we did get a new roof put on, instead of TPO roof, something like that. So if you look at the mechanics from close up, it just looks like a steel roof, but back up a little bit, it is a flat top with a TPO roof there that had quite disintegrated, and we learned that when water was leaking into the building. So got the new roof on. I don't know if you can update on extent of damage inside.
I have not. I believe they just finished up the roof yesterday, or maybe this morning.
Well,
Yeah.
yeah, they started working on it on Tuesday.
Okay. Yeah, that's right. Okay. And we haven't had at that point in time, there was it really hadn't reached inside the building just a whole lot, from what I understand. I was in Texas at the time, so I didn't get to see it. And there was just a little bit of wall damage on one of the walls. And so we're just kind of in that drying out phase. I know that we're probably going to have to replace some insulation up there in the attic and you know, take care of some things like that. But I haven't been over there yet to take a view, see what the damage is. But as soon as we could, we got in contact with some roofers and pulled them off vacation and everything.
Is,
Come out and do it. So
is TPO that membrane? for the-
yes. Yes, it is.
And so this was sun damage, basically, just UV rays disintegrating the original material or something?
A lot of it, yes, it's, TPO is generally a pretty good, product for this kind of climate and everything. But it's still, and there's no telling how long it's been up there, but it has a shelf life of about 20 years.
Do we do any sort of inspections on some sort of regular basis to kind of grade where we stand with? the quality
Yeah.
Of important surfaces?
Yeah,
like
we
this?
have, and we went through and re-roofed a couple buildings, internal medicine, and then over here a couple of years ago. So yeah, we do. Yep, and then they did come and they evaluated this roof. They did look at sections of the hospital roof as well to take a second look at. There are areas of this roof as well that we'll need to give some attention to in the very near future.
Sounds like it was a quick remedy though for the,
Yeah, thankfully, we've a good report with, is it Wagner?
Wagner.
Came out and, yeah, looked at it and was like, because new room, because this, we got water coming in and they were on it.
nice.
Yeah,
And our engineering team, they were very responsive to it too. Got in there as fast as possible.
Great.
yeah, George and Trent were in there quickly and got buckets catching all the water and getting it outside as it could. To minimize the damage there.
Any other questions for Jason at this time? All right, moving on to Chief Human Resources Officer Janine. What do you got?
Well, we have our dashboards and data for you if you have any questions about those. Did want to give a bit of an update with, you know, last month we talked about the sort of manual review of travel agencies and contract management and that sort of thing. We are rolling out a new process where instead of our managers having to reach out directly with the contract agency and sort of negotiate independently, they will now be funneled through what's called Before Health, which is a contract management administrator that is done through the Rural Collaborative. And so what that will do is then our managers and directors will just have one point of entry And then that contract management circle will do the negotiating on our behalf. They will do credentialing on our behalf. It'll be a lot faster. And then we also have the bargaining and purchasing leverage through the whole collab as a whole, as opposed to just trying to, our directors who are desperately trying to get something filled and worried about filling their schedule. The person negotiating on our behalf is just a little bit more leverage. So very excited about that. That is set to roll out in a couple weeks.
They'll also be using our time clock system, so that'll be really nice. It'll be one integrated billing cycle as well, so they'll clock in and out in real time, and then they'll generate one statement to us. We have a whole slew of current contracts with agencies, and they can bill us either a month after or 6 months after. So that's a constant chase from the accounting standpoint, trying to get it right here.
And then the other thing is we'll be able to report out on, exact time of use as well in one centralized way. So very excited for that body of work. On the recruitment side, we do have some areas that need a little love and attention right now. Cardiopulmonary, respiratory therapy, home health, those two areas in particular are needing a little love and attention. So we have talked about refreshing a sort of marketing initiative. Michelle has been really wonderful in helping us kind of establish what that's going to look like and how we can kind of be focused and intentional about the way that we're recruiting. Historically, we've done sort of post and pray. And then try to recruit them. And what we're working on is to try to flip the script a little bit and be a little bit more intentional in sourcing. So very excited about that. That body of work is beginning.
We have two recruiters, a physician recruiter and then our staff recruiter. So both will now report up through HR and through Janine. So there'll be some good synergy and commonalities of how they recruit and source.
Yep.
That's good redundancy.
And just support for each other too, yeah, I think that'd be great. On the HRIS update, we have finished all 3 demos for the HRIS systems. And we think the committee will be able to put in their recommendations for the HRIS update from there. And then our LMS, performance management and competency, that kicks off with HealthStream. We're in throes of kickoff with that. So yeah, just a lot going on all fronts, but it's all kind of coming together. So at the end of the day, it's just going to be about data, right? You cannot make bricks without clay. So very excited to get that up and running.
Excellent.
Yeah, these systems, something I'm really excited for, these new systems, we're looking at a lot more robust onboarding systems for one. So onboarding checklists go through, all the different pieces by position, set up by position. Onboarding checklist for physicians different than a nurse, different from an accountant. So you're able to set up all those and make sure everybody and everywhere is aware of that onboarding, and then tracking position control as well and span of reach. So they show org charts really by area, and we can quickly assess the size of the team and the individual placement. So when you're requesting an FTE, we can see it as the whole team, not just one more. And then they also check back to actuals versus their position controlled FTE. So you can do reports on what we hired versus what's running. So I'm excited for this new project.
Very good.
I have a question, CMS requiring that 5% of hospice hours are provided by volunteers. Is that related to outcomes or satisfaction, or what's the basis of that requirement?
I'm not exactly sure. I don't know. Rhonda, do you know?
It's just a CMS regulation. They want and recognize the value that the volunteers bring into the program. So they feel like it's important that, I guess, they have that measure so that the agencies are utilizing volunteers in their program to help the patients.
perhaps something to do with people from the patient's own community being helping? Is that?
No, it's our
Nobody really
formal
knows?
volunteer
you're-
program. It tracks
you're
the
giving-
volunteer hours compared to clinical hours.
You're giving CMS far too much credit.
Okay,
That's a great question.
I'll do a deep Google later, see if I can find it.
It came out of somebody's left ear,
Okay, all right. Left, yeah,
we hope.
thank you all.
Any other questions for Janine? I was just gonna ask real quick on your 12-month rolling average graph. The December one is at 0%. Is that just because this is only going through November?
Yeah.
Okay.
Yeah.
Any other questions or anything else you'd like to add, Janine? All right, then moving on, we are at Chief of Facilities, Wayne. What's the deal?
I have something that I brought in and it's not included in the packet yet. Give you something to look over. If you have any questions, just please let me know. Everything right now is it's going well. We are.
So this is the thing you left at our desk here?
Yes. Yes. And so, as far as the expansion project, we're moving along well. We are kind of at that position now where my thoughts, start going out, towards closing. And, you know, everything that we're, going to have to deal with as far as that goes. Make sure our permits are where they need to be, that we're have our inspections with the Department of Health and all of them lined up. So, probably one of the hardest points right now is everything moving so quickly and the project aspects and scope being much smaller. And what I mean by that is there's no structural anything. It's just mostly, small renovation and remodeling. It all moves very fast, and so coordinating with our departments is really tough. If we don't coordinate well, we have issues, and you know the department, whether it's getting patients around to where they need to be, or infection control issues, or something like that. And then also, if it delays us with the contractors, then the subs will sometimes move their people off this site onto another site, and that can cause an issue on trying to get them back here to finish it. So it's very, yeah, there's a lot of coordination. It's a big dance right now.
We did start the, oh, go ahead.
I was just gonna say, I like how you have the milestone and completion dates cluster. It makes it really easy to follow along those important dates. I appreciate that.
Sure.
Yeah, and we did start up the ortho general surgery vascular ortho renovation project too, so they're going full swing in that project. General surgery vascular moved went a little bit to the old orthopedic space. They like their new space. And general surgery is being renovated, and I think that's supposed to be done in February. And then general surgery vascular back into their space that'll then be renovated, and then orthopedics will start. And wound care, we anticipate moving. They're currently in what was Ellensburg Pediatrics, that's where wound care is right now, and they'll flip over to the old Valley Clinic temporarily as well, while that space is being renovated.
What does that look like when you move a clinic? Are there like moving ferries that can, how is that? It happens so frequently and. but
Yeah, we're
so
getting good at it.
smoothly.
Yeah, we're getting real good at it. So
It's another dance for
Yeah.
sure.
So you just come in and just scoop everything and.
We,
It was planned in phase. I mean, a lot of planning went in and figuring out timeline and when we could do it without impacting patients. And you're involving IT because they're moving computers, and it's like, we'll move this section first, but leave some here because we're still taking messages and trying to take care of patients. And then it's staff like the week before, box everything up, get it out of drawers. And then engineering swoops in, carries everything over to the other place. IT comes in and they go back and forth between the two clinics, moving computers, printers, phones. And then staff just kind of fill in all the gaps in cabinets.
I just want to call that out because you all make it look very easy, like there's not a lot of hard work, but I know that there is, and to make it look seamless.
It went really well. They loved it. And then you feed them too. I mean. We bought them. Got to feed them cookies. So, but it is amazing to see all the different departments come together and
Really
make it happen and happen quickly. And the fact that they can find everything, I think is amazing.
Good job. everybody.
And signage for patients, so,
Mhm.
yeah, Michelle and her team's gotten up notices of signage for patients, so it's been seamless. This one's nice because even if they forget, they just gotta walk a little bit further. It's been a little bit more of a struggle for our wound care patients because they're used to parking where it's fenced off now on the west side of the clinic, so they are having to walk a lot further, having to park in the front and walk down the sidewalk and down to wound care, which has been difficult for that subset of patients. So wound care patients, often it's foot issues as well, so transport has been tough.
That's one reason why we've tried pushing moving wound care over here to this Valley Clinic a little sooner than what we originally planned. To try and help them out, get closer parking.
Yeah. All right, any other thoughts from your side of the? Any other questions for Wayne? All right, thank you, Wayne. Moving on into operations. And with that, we like to again welcome Deb Callens as the new Chief Nursing Officer. And do you prefer Deborah, Debbie? What do you?
I honestly don't have a preference.
Okay,
You can call me, I'll answer to all three, but a lot of people call me Deb, or Debbie,
okay.
but I'll answer to any of them.
Sure.
We have a lot of Debbies now here, and Debs and Deborahs, and so I think it's gonna be complicated for.
Maybe we should call you Super Deb.
So- Oh, I know, don't call me, please.
All right, do you have a report for us then?
Yes, there's one in there. I just want to call out a couple things. I'm very new, but this is the team I inherited, so I thought I would call out a couple nice things the team's been doing. First of all, back to the expansion and the OR expansion, the OR team has been through a lot of tremendous changes in the last while, moving things around and just like what you were describing, but while taking care of patients. And in the OR, I think it's important to call out the complexity of keeping your environment sterile and safe for your patients while you're doing, I'm sure Wayne's feeling the same pressure as the staff caring for the patients. So I just want to call that out. They're very excited about some of the space that they have now, that they are utilizing, and it's beautiful, but there's a lot of nuances that come with that. So I do want to call them out for that, the great work that's happening. The first time ever, we have an FTE in place now for a registered dietitian to work on the weekends. I thought that was really exciting. And so we will be providing Saturday appointments as well for nutrition and diabetes education, which is also exciting. We're expanding our services for access. And then the CNA training that's up and coming. There's, I think this is past now, the 21 applicants, but we have 6 incoming cohorts. You might know a little bit more about that, but that's really exciting that we are providing that type of education to help build a pipeline in our community. So other than that, I don't know if you guys have any questions for me.
Questions?
That CNA training came up too in the Teamsters negotiations, so it's well appreciated by Teamsters and those employees. So trying to get the workforce as complete and filled out there as we can to minimize their floating back and forth. So
Yeah.
in general, floating isn't most people's favorite thing. So doing this effort to get fully staffed has been very appreciated. So thank you for the support.
The night shift RN's been a little tricky to.
I would say not uncommon in healthcare today. I do think that just what Janine spoke to for these hard to fill positions, I think we can get creative and do some maybe new things that we haven't either done before or haven't done in a while to see if we can start to recruit for those positions differently.
Any other questions?
When you were talking about diabetic education,
Mhm.
did you say that was the first time we were doing it?
No, the, on Saturdays.
Oh,
So
the
it's
first time on Saturday.
expanded,
Okay.
yeah.
I know historically we had a dietitian, Mary Jo Morrissey, and she became a really good diabetic education. And I even saw some of her education meetings historically, and it was really good. Because she used to talk to so many people that were diabetic, and it's really good that we're still doing that. And having it on Saturday would be even better, because then people won't be working as much, and they can get a lot of good diabetic education.
Agreed. Thank you. Yeah.
Thank
It's
you.
Exciting.
I just wanted to extend a welcome. Glad you're here.
Oh, thank you. I'm very excited to be here.
Anything else? Thank you. And then we're on to Chief Ancillary Officer Rhonda Holden. You have a report for us?
Yes, I do, beginning on page 60. A couple of updates under home health and hospice. We actually do have a home health aide that has also gone out on FMLA. So we're having our per diem home health aide help us out, which that's great that she's been able to do that for us. And we would also like to thank the foundation for their donation of a bladder scanner to the program. So we're really excited to have that because we use it quite frequently on our patients. As far as cardiopulmonary goes, Carolyn is told us that she's going to retire probably in April or May. She has the majority of her family lives in Virginia, so I think she's missing her children and grandchildren. And I really appreciate that she's given us a really good long notice. So we'll be looking at how we might want to structure that department with her departure. And I mentioned a couple of places, pharmacy and imaging, about Multicare Memorial increasing wages, and they also have done that with labs. So that's making it challenging for recruiting positions for us. I think it's a huge disruption for our area with the increases that they are said to have been given. Other than that, that's all of my updates, but I'm happy to take questions.
Questions for Rhonda? So the wage increases is making it tougher to recruit. Is it also potentially causing us to lose people?
Yes. So the directors are really working hard with HR and Jason and their staff, letting them know that we are looking at the market and we're making adjustments where we can, and that we will continue to do so. But we really do anticipate that our staff that live in the Yakima area or Sela may decide that they want to just transition there. So it is a huge risk for us.
Okay. And is what they're doing, is that an anomaly? Or are they somehow reaching more, average of the region or the nation or whatever? It just seems, it's such some drastic increases. It's just, I'm curious as to what their strategy is, other than to scoop up as many people as they can.
Yeah, I think-
On the curve too.
Yeah.
Their level setting, they're Seattle based.
So, okay, since they're a larger organization with a footprint in Seattle, they're, okay.
Yeah.
Yeah. So they have staff that work in Seattle and staff that work in Yakima. And so they're trying to think, level across the organization as far as their wages go. But, they haven't really taken into consideration the cost of living in Seattle compared to the cost of living in Yakima when they made those adjustments.
Yeah, interesting. Okay, thank you.
Thank you.
Anything else for Rhonda? All right, thank you, Rhonda. All right, moving on to Stacy, Chief of Clinic Operations.
Yes, my report starts on page 61. I want to talk a little bit first about the medical apprenticeship program we have. We did have approval for 2 slots. We had over 30 applicants. The challenge we're having is not enough staff want to be a preceptor. So the MA apprenticeship program requires you a dedicated preceptor for that entire program length. That program is 1 year. We then give them 90 days to sit for the certification with the state of Washington. But what we're seeing is once people are getting certified, we are still seeing the state take 3 to 4 months before we actually get that certification. So for that entire time frame, they have to be precepted and have only one person assigned to them.
So like 16 months.
It could be like 16 months if you brace it out the whole 90 days before you take your test and then figure another 4 months for they to actually get your MA certification to you. So we're meeting, Shelley, our MA development coordinator, and I are meeting with the MAs who are eligible. Requirement is you have to be working as an MA for 1 year and have a conversation about what are some of the barriers. We don't think it's pay. That hasn't been brought up, but what has brought up from staff is I'm too busy or I don't want the responsibility of having a preceptor. So we're gonna try to look at creative ways to do it. Another thought we had is once they pass that certification, a provider can be named as a preceptor. So we feel pretty good that if they pass their certification, a provider could be that preceptor and that would help free up some of our other preceptors. So we've got a couple things to work on that program, but we'll only be accepting 1 student in January. Otherwise, consistently, we've accepted almost 2 every quarter.
When you say that there needs to be, I think you said a dedicated preceptor, so let's say I am a student. I have one particular person who's my preceptor, and if they go out on leave for.
If they go on a leave, then we have to move them to the clinic where a new preceptor is working.
So
So
there's
that's the,
provision for replacing it, but it's not like you could assign 5 different preceptors to 1 student.
correct. And only each preceptor can only have 1 student.
That's very limiting.
It is very limiting, but I can tell you it is amazing program. The MAs who go through this program and stay and work with us are levels above the MAs we see coming out of charter or PMR, some of the other programs. That year-long time with us sets them up to be so successful and starts building that provider MA relationship up front. So yes, it is a lot of time we dedicate to it. And we still see about 70% of them stay on somewhere, either as an MA or in the program somewhere. So just to let you know, we are going to be meeting with them. We're doing some lunches with them to sit down and really talk about what are some of the barriers and how can we get creative. We might look at, okay, maybe it's you precept for a month if they're up at FME, and could we rotate people between 3 preceptors? And it's just, you do it for a quarter, you do it for a quarter, you do it for a quarter.
So signing on for a year of precepting.
Versus signing on.
Could we incentivize them monetarily?
They are paid $1.50 more an hour when they precept. So there is some money already there. And what we're not hearing is, I'm not getting paid enough. What I'm hearing is, I just don't have time in my day and I just don't want that responsibility. So we're really gonna sit down and look at that.
Yeah, it's not just them to do it from other areas to the precepting, it's the responsibility. It's not wanting that additional burden or weight.
It is a unique problem to have, and talking with other people in the Rural Collaborative, they're struggling even to get applicants for an MA apprenticeship program. So they've got apprenticeship programs, they just can't get.
That's crazy. Tremendous opportunity.
It is. It is. And then just a little bit about rapid access. They just like seasonal increase. They have also been extremely busy. We had a high of 42 patients. And then on the 23rd of December, they saw, I think it was like 53 or 56 patients in 1 day. 1 day, 1 provider and 1 MA. I'll caveat that. Colin was like, we need more staff. And then it was Christmas Eve, we saw 8. So everybody stayed home. Nobody wanted to show up at Rapid Access on Christmas Eve. So we still see that influx there in volumes. We're averaging still about 21 patients a day, Monday through Friday. And then Saturdays, we've upped it to about 12 patients, which is better than we were running about 6 patients a day on Saturday on Rapid Access.
And do you feel Rapid Access is achieving its goal of why it was created?
I think it is working so well. We've got to figure out how we keep the schedule upstairs. We used to hold a lot of same-day slots at FME, and patients now are not even calling their primary care clinic. They're just walking into Rapid Access. So our PSR downstairs, when patients start to stack up, the first thing he does is look for patients that are FME patients that who's has an open schedule? Can we get them seen upstairs quicker than we can sitting in rapid access? So it has some challenges, but the word is getting out.
Yeah, they were impressive working the front desk there, getting patients plugged in upstairs or
Needs.
waiting for rapid access. I sat in there for a little bit. I went to stop by and check in with one of the providers, and it was a busy day. I was like, I can wait for a little bit. I'll stand here, watch them rush around. I was watching the PSR scheduling at the front and calling and trying to plug people in at their floors. It was awesome seeing that as a portion of the service. So it wasn't just coming to rapid access, but trying to find the right place for you to get timely care.
Both
Ended up-
peds and ENT help take some of those kids and sore throats and those kind of issues first.
And I believe the rules are you need to have been a patient here in the last 3 years.
You have to have had a
Is
visit.
that any friction point? You get people coming in who don't follow that rule, and what do we do if it happens?
We've had probably a few that have come in. We can get you established care.
And we've had a few established because of it. So
Mhm.
come back and they find out they have to be established. Like, oh, I guess I need a PCP too.
Okay.
The piece with it is if you continue to expand it, today is a market of on-demand service, so continue making appointments for your primary care physician, for with this model, it encourages just walking in, so we
Yeah.
have to just have a place there.
I'm open for questions. The other thing, the photos, I've never seen people so happy to move into a temporary space. The one caveat they really love is vascular has its own exam rooms on the left-hand side. So they got to put up their own art in the exam rooms and veins. That was what they were really excited.
I had several people, last year, tell me that they were very happy with our rapid access. They know I'm a commissioner of the hospital district, and they said it was very great that they could rapidly go in there and they don't have to come over to the emergency room unless the rapid access thinks that's a better place for them to go, because the rapid access is doing a really good job determining what kind of service they need. And then also they said they also were able to get an appointment to their primary care provider. So the rapid access is doing about 1,000% great stuff for our area now.
Thank you.
Any other questions for Stacy? Thank you. All right, moving on to the medical staff, chief of staff, Dr. Hoppy.
Yes, good evening. My report is on page 65. As you can see, we had kind of a lighter month in terms of having to review credentialing files. There was a total of 8 with 1 initial appointment and 7 reappointments. I'm happy to answer any questions.
Any questions? Right. And I assume we want to do the appointments. So if we have a motion to approve the credentialing files.
I'll move to approve the slate of credentialing files.
Motion by Erica, second by Bob. Any further discussion? All in favor, say aye.
I,
Aye. Anyone opposed? That motion passes. All right. Thank you, Dr. Hoppy. And now we're on to Chief Medical Officer, Dr. Martin. And I just want to say from the board's perspective, I believe this is your last meeting in this role, and it's been a pleasure to work with you over the years. And you've always been so kind to answer my questions and pass along your knowledge anytime I had something for you. So I personally just wanted to say thank you, and it's all yours. The floor is yours.
Report begins on page 66. I started with a recap of what we accomplished in recruiting during the past year. We've complained a lot about the challenges, and I thought it was worth calling out some success. I'll also call out one error in this. It says that I've been CMO for not quite 6 years. It's actually not quite 7. But it has been a real joy working with this team and being able to be a part of how this organization has grown. And I just want to say thank you for that opportunity. Any questions?
Any questions?
Again,
agree with what the huge impact on our healthcare community that we have here, and appreciate your inputs and some of your corny jokes. We'll be yes for sure, and hopefully our paths continue to cross on different aspects. And
I was doing a grand rounds when I was a third year resident, and afterwards my residency director came up and said, the thing that I really love about your sense of humor is you don't care if anybody gets it. You're just doing it.
We're in a clinic and puns and goofy humor.
congratulations.
Yeah. And for those of you, there's a handful of us here that were at the board meeting on March 29th, 2018. When Dr. Solberg gave his last report, and it was at this point of the meeting that he said, I guess I'm done.
Oh, my God. Thank you.
Thank you. Any further questions for Dr. Martin?
Hope not.
All right, moving on to finance. Jason's still handling the load of CFO in addition to CEO, so.
Yeah, so reporting on November, even though it's January, but I'll touch a little bit on December as well. So November volumes came off of October was really high volumes, high revenue, everything was strong. November was mixed. It just flipped a little bit. November is one of those shoulder seasons. It tends to be like that. So our budget is actually a budget loss in November even. We didn't end up as far of a loss as we had anticipated. So we resulted in an operating loss of $52,000 and a net income of $97,000, compared to the budgeted loss of $659,000. So really looking at trends and how November shapes up between the holidays and the weekend days in the month, quite well considered. A lot of this has to do with the safety net assessment program. So we've really reduced our contractual adjustments this month, but it's not because insurances are paying us more. It's the SNAP program that Lucia was able to negotiate for 2024 and 2025. So it resulted in about $1.9 million positive for us this year, and it'll be the same next
So
year.
one more year for that program as is.
As is, and hopefully we'll learn that something comes to extend this increase. Otherwise it'll go back to what it was prior to 2024, and it netted KVH about $80,000. So a massive increase there in that advocacy that Wisha did. And to call out Wisha, they did a lot of work to get this program underway. It's a federally matched program, so they had to go through a lot of effort at the federal level to get this. Revenue cycle team to call out. So we did a lot of restructuring of that group in Q4, late Q3. Things are going really well with the team. The culture is very strong. The team's very strong. We got about $7 million off of accounts on hold that we've turned into real cash, and AR has dropped considerably in November from 49.8 million to 46.1 million. And then touching on December, I think we're down about another $3 million as well. So their collection efforts and processes they've been implementing has made significant differences. The next phases of this through 2025, you'll see we have a QAPI just around revenue cycle. So anticipate a lot of changes in our claim collection processes, not just outward facing with patients, but also our internal processes, how we work with insurance companies as well, and registration, scheduling, everything. Total days cash on hand increased from 164.1 days to 164.6 days. Any questions on my report?
Questions for Jason at this point?
I would throw out there, if there's a couple of commissioners would be interested in doing a Gemba with Rev Cycle, they do a weekly team meeting on Wednesday mornings, if anybody would be interested in doing that.
Is that out at Radio Hill?
At Radio Hill, like, maybe we'll schedule it, so.
Yeah, I,
When is that?
They do it Wednesday mornings. I think at 9:30. About that.
What would that
That's
be?
their huddle. A revenue cycle team meeting they do every Wednesday.
Oh,
I'd welcome a couple of commissioners coming.
I'd like to try to see that.
do we create a quorum if there's more than two of us?
I would try to go with two.
So it'll be Bob and Terry then.
Could we do
Okay.
two separate?
And then maybe Eric and I
Can
can
do
do the second.
Yes.
Okay, so we'll be uno and dos, and you can be tres and cuatro.
Probably mostly will depend on how the schedule pans out for each of us, but I think that there's a decent amount of interest already.
So just know we're all interested and, you know, whatever can work out on the calendar for everybody would be great.
Okay, so Mandy will send us a thing that we can put on our calendar to remember about that.
Yep.
Thank you, wonderful Mandy.
Capital items, so we did purchase a few items there noted on the bottom of page 69. Speech therapy scope for their swallow studies, the rapid transfusion blood warming device for the emergency room, that it is a mobile device, so it can be used in other areas as well. And then a mind rate ultrasound for family birthing place, that is the same ultrasound unit that the board did purchase for the emergency room a couple of years ago as well, so standardizing on that piece of equipment, and we needed to get that new equipment with our new OB/GYN docs, and they were requesting that to be a little more prompt than we originally had anticipated, so we got that equipment for them. And the foundation has graciously offered to purchase those items, so thank you, foundation, again.
The foundation did a really good financial support for us.
A ton. Yeah,
Yeah, the group on the foundation is, yeah, just really amazing people and led by an amazing person to give that much money to the hospital. It's huge,
Yeah.
probably the most ever in history.
it's the most ever.
Yeah.
Yep, and you're $510,000 in 2024, so yeah, huge contribution, and it's spread to a lot of areas, a lot of devices, so.
And I appreciate how that was kind of spread out amongst the organization, so,
Those are generous our communities at large as well.
yeah.
Yeah. Really fortunate.
Any other questions on the narrative or the other departments there?
Anybody have any other questions for? I would just say, I know we talked about it at the finance meeting the other day, since Bob and I are on the finance committee and see it every month, just the amount of effort that goes in behind the scenes to get as accurate numbers as possible, both for budgeting and follow-up and stuff. I just really appreciate. I know it's been an ongoing process as you stepped away from the CFO and moved into your new role, the people you put in place. It just seems as strong as ever. And again, from our perspective, it's vital to the hospital, the financial stability to just know what's going on, and a good solid team keeps us up to date moment to moment. And so I appreciate the people I work with through finance and get to meet and stuff. I'm just really impressed by their efforts.
I agree. It's a good group. It's a lot of numbers, to keep straight, and anytime there's a slight typo, John catches it really quick.
That one skill.
Really love the extra eyes on everything, and the visibility that our reports lay out for the commissioners and myself. A couple of stats just to touch on in November that I want to call out. So Stacy Olena's team is just been huge with providing access to communities. So we exceeded our visits by 7% in November, and I think October was 8%. We exceeded budget. So they're doing really good there. And that just stems from the recruitment efforts as well. I guess Dr. Martin's out, so I can't call him out, but Dr. Thomas's team too, working together to just recruit and retain and have good providers, and the recruiting efforts to fill those positions and the needs. So a lot of increase there in Q4 in our visits. ER has been down a little bit in their visits the last couple months. Could that be rapid access? Probably a contributor to it. And then just some natural variation there. I imagine. We are still getting about 8% of our ER visits come from Yakima. So exactly 8% in
That's
December.
holding pretty steady then.
It's steadily increasing year over year. So, yeah,
The people from Yakima?
yeah.
Okay, so that's not why it went down. Memorial isn't doing good down there then.
I think it's just a different place that people are comfortable going to establishing. We have quite a few people established that don't live in our county as well, so using our system makes sense to them. Any questions on the stats, certain trends report? Nothing from me. On page 74, hopefully we'll see as 2020 progresses, any changes on our Medicare Advantage. So we'll continue to, Michelle's team will continue to push the Medicare Advantage options and the differences between original Medicare and Med Advantage, especially during open enrollment times, and hopefully see that curve bend or flatten their road. And that's all I have for the finance presentation. If there's any questions on that, otherwise we'll jump to the budget.
Any remaining finance related questions?
Budget, we'll look for a resolution on the budget amendment. So we're amending the budget that was passed in October that was largely done for the levy. So it's kind of a quicker budget. This is a lot more detailed. So that's the one that we're amending. I have a narrative there on page 81, but I just want to call out Scott Casey, who put this together. So I've been doing budget the last 10 years for the hospital, and Scott did it for his first time this year. Scott's new to healthcare. He's got 10 months into healthcare experience, but a lot of analytic experience that's real transferable to looking at trends and working with data. He went around, met with every manager, mostly doing them via Zoom. That was something that for a budget person, a good thing that came out of COVID, doing them via Zoom is a very streamlined method because managers have their resources at their fingertips and the analyst has their computers to do the work while they're meeting. Anticipate $22.5 million increase in total charges. 47% of that comes from growth in surgical services areas. 24% of that growth is in the professional clinic services. 11% radiology, 10% is pharmacy, family birthing place, and then 8% other. So pretty, I think, reasonable budget, conservative, but not too conservative on the growth, considering the expansion project to come under wraps, and then our continued recruiting efforts and plans with the clinics to continue to grow and increase access. Salaries will go up obviously with that, so expecting salaries to increase at the very bottom by about 6.2 million. Have that broke down between what that is between open positions, cost of living adjustments, market analysis, and some new positions as we accommodate new growth. Total expense projected to go up $13.5 million. Any questions on the narrative of the budget?
No, I just want to call out that for, small public hospital district, KVH, this year, our gross charges were more than $250 million. So, we've really grown as an organization. And the thing I'm excited about is to take what little surpluses we find and continue to grow the business with new service lines that are good for the community, and just try to make sure we can provide really good care for people in our community, and they don't have to go to Seattle or Yakima for a lot of the care that we can offer, which is exciting. That, because again, I was first on the board for 1 year in 2015, and it's just amazing how much we've grown in that time. So, and again, it takes the entire team to do this, but so it is.
Every new service is just another reason people don't hopefully need to go elsewhere.
Yeah, and stay close to family and friends here, so sorry to interrupt, Jason.
That's good. That last bullet too, so other direct expenses, always wonder like what's going on in there. So that is largely recruiting expense and community education expenses. It is quite a higher projected in 2025. And that's just working with Michelle's team, and as you're hearing from Janine and Deb, trying to get a little more creative and intentional of recruiting and sourcing versus that posted pay method. So we hope to market our services and our workforce and really demonstrating and getting the word out of the place that KVH is, how great it is to work here and seek our services here. So anticipate seeing our name a little bit more around town and getting the word out of those services. So if people regular, the community member last week, and they said, oh, sure be nice if you guys had cardiology, it'd save me some drive time. It's like, actually, so just getting our name out there a little bit. Yeah. But we're also, yeah, we've pulled back on that a bit too, because it's been service focused and our practices are full. But it's also trying to get our word out there to candidates for employment as well. So that is all I have for my budget presentation.
Are you looking for a motion on this resolution?
One more point I just wanted to touch on the last page 84. So contractual adjustments is about as significant as revenue charges. So we can charge what we want, and then trying to collect it is another thing. So we do have there that collection rate, you'll see kind of trending over time there. It was lower in 2020, about 52.9%, and then it increased there 55-56% collection rate. And then coming off the COVID times there, you can see 23 and 24, our collection rates have dipped quite a bit. That I can see it as a different positioning insurances have taken since post-COVID. So they are being a much different focus on how to manage what they're paying out, I guess. So we did bump that back up there to a target of 54%, working with our rev cycle operations team to really do as much as we can to combat what the insurances are doing as well.
And so the 2025 budget, we're a little bit of optimism that maybe it'll squeeze it a little bit there. Okay.
That's all I have now. So I'd be looking for a motion too, and then my consent budget.
Okay, so we have a resolution number 25-01 to amend the 2025 budget. There's no further discussion or questions. I'd entertain a motion. So moved. Moved by Bob.
Second.
Second by Erica. Any further discussion? All in favor, say aye.
Aye.
Aye. Is there anyone opposed? So that motion passes. So you need to get a signature on here is, yeah. Do you have a master or do you want to use? Nope, it's got this on the back, so we know.
Should be at your.
I'll find it. We'll find it and get it signed. Okay. Thank you. All right, so anything else for finance? All right, moving on. Community Relations Report, Chief Public Relations Officer, Michelle.
Hey, everybody. So you've got my report attached at the very end there. I did want to point out that since we put that through, we have scheduled a retirement party for Dr. Martin. That is happening January 10th from 4 to 6 at Guard. You should be receiving an invite tomorrow if you haven't received one yet this evening for that. And then the other thing, this is just more of an FYI. A lot of us were surprised this morning to hear us on the news regarding some patient activity that happened historically in the emergency room and some court cases. I have no idea what generated that news. I know it was in Yakima media, and I know it was also in Wenatchee media. And none of us can give you a good reason as to why all of a sudden they were reporting that. But just a heads up. Other than that, I would be happy to take any questions.
Good. Any questions for Michelle?
Oh, yeah. Can you explain that a little? So there's some kind of news thing about.
Yeah, and I'll be the first to admit, it's not really in my wheelhouse. I don't know a lot about it, but we did have a patient, an aggressive patient, that charges were pressed due to damage to the facility and threats were made against the facility as well. And so some of this happened apparently at the beginning of the month. I think some of this was months ago. Again, not my domain, but that's just what they were reporting.
Yeah, there's something in the news I heard about today from somebody from Yakima, like, oh, you guys were in the news. I'm like, what are you talking about? So we're still trying to figure out what exactly that was and why they decided now to report on an incident that happened weeks ago that are in that emergency room, unfortunately, fairly routine. So, yeah.
Must have been a
But
storm in-
sorry
I-
to bring this up here, but I do know one thing that happened last month was we did have a patient 3 years ago who assaulted our staff in the emergency department, and that case is just coming forward in Kittitas County Court. So I wonder if that is sparking some interest in it. There were some hearings last month and this month coming up. So I wonder if they saw it on the docket kind
That
of thing.
could very well be it.
Anything else for Michelle? Anything from your side, Michelle? Anything else?
Nothing else.
All right, thank
Thank
you.
you.
So that is the end of reports. And nothing under education or board reports, nothing under old business. Nothing under new business. I just want to say Dr. Thomas has been on the line also, and I just wanted to welcome him as the new chief medical officer, and he'll at the next board meeting be representing as that moving forward, CMO. So congratulations on that. We look forward to working with you in that capacity, Dr. Thomas. And so we have, it looks like we have executive session. How long do we need for that, I think?
10 minutes.
Okay. So it is 6:23. So why don't we take a 7-minute recess and then we'll reconvene into executive session for 10 minutes. And is there any action anticipated at the end of that? And then we'll reconvene to public session, close out the meeting. So thank you, everyone. Appreciate your efforts.
Happy New Year.
Yeah, Happy New Year.
Thank you, Dr. Hoppy.